Welcome to Chapter 30. This is going to be pediatric neuromuscular or neuromuscular dysfunction. We're going to start with sprains, strains, and muscular dystrophies, and then I'll do a secondary lecture on cerebral palsy, neurotube defects, and hydrocephalus. So, sprains, strains, muscular dystrophies. Here we go. Sprains and strains occur as a result of trauma to a joint. When we're speaking specifically of sprains, this is which ligaments are stretched or are partially or completely torn. Not common in children because of their body development, but it can result from athletic injuries in our adolescence. Strains result from excessive stretch of muscle, also known as pulls, tears, or ruptures. Frequently, again, athletic injuries in our adolescence. Contusions are a soft tissue, muscle, or subcutaneous tissue damage. Frequently are seen with sprains. Dislocation occurs when a joint is disrupted in such a way that the articulating surface are no longer in contact, and then soft tissue injuries are common among children and are usually related to play or athletic activities. At organized sporting events, an athletic trainer or a healthcare provider may be present to treat any initial injuries. The child with a soft tissue injury, the first 6 to 12 hours after a soft tissue injury are the most important in controlling swelling and reducing muscle damage. Swelling can inhibit healing by keeping the ends of the ligaments separated and then increasing fibrous scarring. Treatments of soft tissue injury is summarized with the acronym of RICE. R is for rest, which helps the body use its nutrients and its oxygen for healing process. It facilitates repair by allowing fibrogen and collagen to form across the wound edges. I is for ice, which is appropriate at the time of initial trauma. It promotes vasoconstriction, decreases swelling, pain, and congestion from metabolism in the area of the inflammation. It should be applied to the injury for no longer than 20 minutes at a time, and we want to make sure that we have some type of barrier to prevent frostbite. Compression is RC, which counters the vasodilation effects and the development of edema. When done by direct pressure over laceration, it occludes blood vessels and stops bleeding. We can use bandages to support injured joints that have tendons and muscles unable to provide support on their own. E is for elevation, elevating the injury above the level of the heart, reduces edema by increasing venous and lymphatic return, and it helps reduce pain associated with blood engorgement at the injury site. You're in therapeutic nursing management for the joint injuries. We want to avoid weight-bearing activities for at least 3 days. If the child is of age, we can do crutch walking to prevent weight bearing. If we use an air cast, we need to do education on that. The air cast is going to help to support the joint and reduce the swelling. Those can be worn for several weeks during the healing process. Once the swelling and the pain is reduced, we can start with stretching and isometric exercises. Immobilization and cold application are really effective for incomplete ligament tears. If we have a complete ligament rupture, we may require surgery to prevent scar formation and long-term instability. And then if we have a cast or a splint, it's usually for 4 to 5 weeks that it's going to be required. And we use this a lot with our knee injuries. One of the major functions when assessing our sprains is to determine the severity of the injury. Several variables affect the nursing consideration for a child with soft tissue injury. So the initial presentation, we want to assess the child for neurovascular impairment. And remember your 5 Ps of pain, pallor, pulselessness, or delayed capillary refill time, paresthesia, and paralysis. We might see diminished range of motion. We want to treat our pain with analgesics like ibuprofen or acetaminophen. These are appropriate for pain management for a sprain. And then distraction and age-appropriate play activities can also be effective and helping the child cope with pain. For swelling management, we want to keep the extremity elevated at or above the level of the heart. This position enhances that venous return. We want to use support and immobilization devices. Remember that they should not be so snug that they're going to cut off circulation. We need to assess them frequently because as we have increased swelling, something that the support device or the immobilization might initially fit appropriately, but if they continue to swell, it might become tight. So we need to do neurovascular status assessments before and after the application of any splint, compression device, casts, or wrap. We also need to teach parents to assess for neurovascular compromise at home. If we're using surgery immediately postoperatively, we should use a cold compress cuff. And then we can also do continuous passive motion machines for children. And these need to be maintained and regularly checked. Recovery, we want to teach the parents and the children active stretching and strengthening exercises to maintain joint and muscle integrity. The amount of time needed for healing is determined by the severity of the injury. Bearing weight is gradually increased as pain subsides. More severe injuries may require partial weight bearing exercises, with full weight bearing exercises introduced once the swelling has resolved. Activities may be restricted as directed by their provider. Patient education, we want to review the principles of rest, support, and application of ice with the parents and the child. If wraps, splints, or air casts are used, we want to teach the parents and the children how to assess neurovascular status. If crutches are required, we review the principles of crutch walking with both the parents and the child. We want to make sure that the family members understand activity and sports restrictions, and we want to discuss follow-up appointments and the importance of adhering to activity restrictions until the injury has healed and the child has been cleared for participation in sports. Now, muscular dystrophy. All right. Muscular dystrophies is a group of 30 plus inherited progressive degenerative diseases. It causes weakness and atrophy of specific muscle groups. Inherence patterns and age of onset vary, but most present in early childhood. Duchenne's muscular dystrophy is the most common, and that's the one we're going to cover. The pathophysiology. Despite clinical differences, muscle changes are similar across types. Muscle fibers leak creatine kinase, and calcium accumulates. This leads to further muscle fiber damage. Muscle fibers degenerate and then are replaced by fat and connective tissue. This results in progressive weakness and symmetrical muscle wasting, leading to increasing debility and deformity. So your clinical features. Age of onset, it's usually identified at 3 to 4 years of age. Parents notice gait abnormalities, difficulty getting up from the ground, and frequent falls. Early signs, we're going to monitor function changes. So the waddling gait caused by pelvic girdle weakness is something that we're going to see. Then as a child gets older, we'll see gower sign, that's GOWER sign, and this is characteristic method of rising from the floor by climbing up the legs, caused by weakness of the lumbar and the gluteal muscles. Child uses hands to push up on thighs and legs to stand. We might see that they're having frequent falls and clumsiness, difficulty running, jumping, and climbing upstairs, and also toe walking. Our physical appearance, we have pseudo hypertrophy of the calf muscles, which means that it's like an enlarged calf. It's actually replacement of muscle with fat and connective tissue, and it gives the appearance of muscle development, but it's not. Instead of having strong muscular calves, we just have fat and connective tissue. The foot assumes an inward and downward position, weakness of the anterior tibial and peroneal muscles. Disease progression. So at 3 to 5 years after onset, we have our shoulder girdle muscles become involved. progressive upper extremity weakness, and difficult lifting arms over their head. In school age, we have increasing difficulty with activities in daily living. They may need assist devices, and we start to see scoliosis develop. At 12 to 15 years old, we have loss of ambulation. They're usually wheelchair dependent. And then they get progressive respiratory insufficiency, cardiomyopathy develops, and orthopedic complications, um, including scoliosis. And as we're starting to have that progressive respiratory insufficiency, we get worried about common colds and things that could actually be very detrimental to these children. In late stages, we now have a severely compromised respiratory function. We have cardiac complications. We have constipation and incontinence, and they presume that this is possibly from smooth muscle involvement, and we start to see contractures and skeletal deformities. The cognitive impact, cognitive dysfunction is common and often overlooked. Full scale IQ average is about 85 compared to a normal 100. And it may be due to specific learning disabilities rather than true decreased intelligence. It doesn't progressively worsen, and education support is often needed. Life expectancy, death usually occurs from respiratory tract infection and compromised respiratory system. So, again, really important that we're making sure that this kiddo is getting their vaccines and we're not exposing them to environments that can place them at an increased risk to get the common cold because the common cold can kill them. Majority of their life is usually they live only into their mid-20s. They often require ventilatory support, and then cardiac complications are becoming more seen with mortality. So our care for muscular dystrophy. Once the diagnosis is made, nursing support becomes essential for the child and family. They need to focus on therapeutic management and lots of education. So we want to teach the caregivers about how to modify the environment, make dietary changes, recognize complications, and perform daily safety care. I mean, perform daily care safety. Sorry, let me mix those up. So for your nursing assessment, we want to evaluate family coping with chronic illness and poor prognosis, watch for depression, withdrawal, crying, provide emotional support as needed, monitor for mobility and self-care abilities, monitor for weight gain and respiratory infections. Therapeutic management, we can do surgery, bracing, and physical therapy to reduce contractures and maintain mobility. We can do some muscular dystrophy, specific treatments like steroids, ventilator support, and scoliosis surgery. We really want to prevent obesity to reduce stress on muscle and joints, and urgent attention to any infections, especially respiratory, because if it has the potential to kill this client. Home environment modifications, we need to modify the bathroom and toileting areas so that we have wheelchair access. We have to adapt clothing to simplify dressing while preserving their peer acceptance. We want to adjust the diet to increase fiber and reduce high-calorie carbohydrates. And again, prevent exposure to children with respiratory infections because these can kill these clients. Multidisciplinary team approach, ongoing care coordinated by multiple specialists. Therapy needs to be individualized, and we might want to do genetic screening and counseling for family members. Parent education, we need to ensure the parent can perform daily care. So how are they going to encourage fluid intake? What are they doing to maintain a bowel regimen? How are they promoting safe independence and activities? They need to support range of motion and mobility. They need to assist with position changing every 2 hours. We need home referrals for home care equipment like the motorized wheelchairs. We need family and peer support groups, and there's many of those out there for muscular dystrophy associations. And that is the end of this lecture. Next, we'll be doing neurological conditions, covering cerebral palsy, neural tube defects, and hydrocephalus.